So then when I start to work in China, we're always thinking what are the diseases that affect the Chinese population most, because we want to have a greater opportunity to really study the disease when they have a lot of disease in the population, but also create impact. It's well known that the prevalence of myopia is much higher in the East Asia population. But when we start the study, there's actually no population-based study on the prevalence of myopia among school-age children, because most of the study at that time was conducted in school basis. Even when the study involved very young children, like 6-7 years old, people still use tropicamide. So this psychopicture agent is not strong enough to have an accurate measurement on the refraction. Then we work with National Eye Institute with the grant support. We run the first population-based study on myopia in Chinese school-age children in the urban city. So we use psychopentolate as a psychopicture agent, and then we also enroll the study participant, so-called population-based, and we report the prevalence of myopia in the 5 to 15 years old. This become IESC study. So in the IESC study, it's actually a multiple country study. It allows us to really compare the prevalence of myopia among different ethnic groups using the same methodology. So if you look at the 15 years old children divided by minus 0.5 diopter as for myopia, actually the study proved that in South Africa, India, Chile, the prevalence of myopia actually very low. But then the prevalence of myopia in Malaysian, and also in particular in the urban Chinese population among 15 years old is very high, reaching 73%. So this is the first population study proved this either geographic variation or ethnic variation on prevalence of myopia. So then why the Chinese people got much higher prevalence of myopia? So we decided to run the twin study to answer what is the genetic and or environmental contribution to the myopia development and also progression. So the Guangzhou Twin Eye study starts from a twin registry in Guangzhou city. So it's one single city twin registry. We registered 9,000 pair of young twins, 7 to 15 years old, but also 3,000 elderly twins. Primarily focused on the young twins. We started phenotype and DNA collection in 2006, and then we annually visit them until 2019. So this is a 13 years longitudinal study. We examine them every year. So this long-term longitudinal study with annual visit data really gives us the opportunity to understand how myopia is developed and how this myopia is progressed. So for example, this is one of the study we published. Actually, before the development of myopia, they got a much greater changes on diopters and also axial lens. So the axial lens and refraction is actually start to accelerate progress before and then slow down the progress after the onset. Then we also allow us to look at some clinical relevant questions, because when we practice, a lot of patients come in like 7 years old, myopia, another patient develop myopia at 12 years old. So which one we should start a more aggressive treatment like low-dose atropine or ortho-K? So we look at this long-term longitudinal data, and then we try to find out what is the probability to develop high myopia at adulthood, which means when the children turn 18 years old. So actually we found out for the children develop myopia in age 7 to 8, they got a 52 or 55 chance develop high myopia when they reach 18 years old. But then the risk of developing this high myopia in adulthood is actually significantly reduced if they develop myopia only at the age of like 12 years old, significantly reduced. So it gives us some clinical implication to understand in the clinical practice what should be prioritized for myopia control treatment. Because all these twins have GWAS data. So we look at the genetic risk score based on the known SNPs, the GWAS study. and then we create a genetic risk score. So we put this genetic risk score into different models, and then we kind of prove that in terms of predicting who would develop high myopia in adulthood, actually different model, the model with age square and says or specific, age-specific refraction data is already sufficient to have a very accurate predictions on the high myopia development in adulthood. But then adding a genetic risk score doesn't really help on the modeling, on the accuracy. As you can see from this AUC, a very simple model already achieve AUC 0.95. But then when you're adding a genetic risk score, it doesn't really help on the accuracy. More interestingly, if you have one baseline data, but then you have two visit data, for example, the patient come back again, when you use a 3 visit data, then you can actually slightly improve the accuracy from 0.95 to 0.98 if you have 3 time point measurement. And then we look at the parental myopia distribution and also the children, the siblings distribution, and also the similarity between the monozygotic twins and dizygotic twins. We kind of prove that the environmental change, in particular the schooling intensity increase, will really drive the mean of the refraction distribution toward the myopia, but then also increase the variation. But then in terms of the variation, for example, one kid got -8, another one got -3. Quite a lot of this variation actually should be explained by genetic factors. So we also look at the longitudinal study. So this is a study we enroll children in primary school grade 1 and junior high school grade 1. We follow up them for a couple of years until the graduation from the school. And then we publish a paper in JAMA Ophthalmology, and then it's by chance, this study was cited by independent UK newspaper, very popular Chinese newspaper, also cite this study, and then we really attract the attention from top leadership, and then this become a nationwide policy. But then this has become a national policy to promote myopia prevention and myopia control in the Chinese children. We also run a study, try to prove what is the effective prevention strategy for myopia. Before we run the study, there's already a lot of evidence from Sydney myopia study and a lot of other population-based study or clinical trial in US prove that there's an association between the time spent outdoor and the onset of myopia and myopia progression. But then we run a clinical trial to prove this increased time spent outdoor is actually a causal effect for reducing myopia onset in children. So this is a 3 years clinical trial. We prove that if you change the school curriculum by adding one, we call it outdoor class, like 40 minutes per day as an outdoor class into the curriculum, that will reduce the myopia onset by at least 20% in 3 years' time. So this conclusion is important because this is really the first time to prove that simple school-based intervention with almost no cost will significantly reduce the myopia onset or probably delay the myopia onset that help reduce the prevalence of myopia in the population. So then we start from this idea, outdoor, like basic increased exposure to light that will prevent myopia onset. But then in order to maximize this outdoor or increased light exposure to prevent myopia, I work with Dr. Layton Condon in the rural Guangdong province, established this, we call it bright light classroom. So to maximize the exposure to light, and then we prove this is effective in terms of reducing myopia onset. But then this kind of classroom is pragmatically is quite challenging because it's so expensive to build a new classroom, very expensive to minimize this, we call it greenhouse effect, to keep the temperature normal, very challenging. So how about if the light exposure to people's retina or effective treatment or prophylactic treatment. So then can we do a local retina light exposure? So would this be another new strategy for treating or controlling myopia progression?